Good afternoon, everybody, or good morning, or good evening. Iron load in hemoglobin disorders. Well, why is it so important to worry about iron? As I'm sure you all know this slide very much. You've seen it before. Basically, because iron overload affects more or less the whole body, but our biggest worry is what does it do to the heart and the liver? When I was 10 years old, I was given this gun. Yes, it is a gun. And I was told to use this for my chelation. I must admit and tell you, it was very, very painful. Then we moved on to bedside infusers. Although better, they were totally impractical because you had to stay in bed. Then we moved to the new technology things that were at least mobile. You were able to get out of bed. And then we moved to the ultimate, which is the infuser, which is basically prepared in the hospital and delivered in our home. What I'm going to focus here, why I'm showing you this, is the development of the chelation therapy. And basically the biggest revolution to the treatment of thalassemia happened with the creation of the oral chelators. I'm sure you all know this, each one of those different chelators, the usual dosage and the parameters. And as I'm sure you know, each one of those drugs that we all use, unfortunately now, from what we understand, the market is full of generics or fakes, and this is something that TIF should now start investigating because it is a worrying factor. What is it that we need to worry about is what happens to these parameters of the iron. The serum, these are the different monitoring of the chelation therapy. The serum ferritin is the one that everybody knows, is the easiest, simplest, but unfortunately is the most weak in accuracy of what it actually is happening. Of course, then you've got the MRI, T2 star, the MRI of the liver, iron. Creatinine is also very, very important. And then that indicates what is going on with the pancreas and the ALT, AST of the liver, RIs, and any urinalysis is important to look at continuously. I'm back to this slide again because I want to focus basically on this not between 92 and 2005. If we look at what actually did happen, this is a number of deaths of patients with thalassemia major in the United Kingdom by intervals of 5. These are different 5-year periods that indicate, and this is the important thing here, whereas all of a sudden there is this fantastic drop of the amount of patients who have died. We believe that this is due to exactly the creation of the oral chelators. As you can see, it also matches up with the years, and from 1997, especially when the combination of the deferoprone and the stereoxamine started working very, very well. As this is the part of the presentation of the previous slide. In 1992, T2 star CMRR was introduced in the UK, and doctors caring for thalassemia patients were informed of the high cardiac death rate and new options for iron chelation therapy. There has been a 71% reduction in the annualized death rate from iron overload since 2000. But of course, we still have challenging points, which is things like, when do we start chelation? What chelators do we start with? What do you do with thalassemia patients who are pregnant? On what basis do you alter the chelator? The incredible cost of the chelators, the use of combination therapy and what combination, adherence to chelation, not perfect, even with oral chelators, and MRI, T2 star and Ferriscan, challenging and expensive. So why is this, sorry, what happened here? So why is this a concern for the patients? Well, because in many countries, unfortunately, there's still a situation where no measurements are taken at all, or they're basically irregular measurements every now and then, whenever, especially when patients have to pay. There's no monitoring of measurements. So once you've got the measurement, nobody looks at it in order to take action. The measurements are based on non-calibrated machines. And that actually is quite a deadly situation, because the patients have to spend a lot of money to get some form of report, which unfortunately the actual report is useless because it doesn't give them the accurate situation of their body. And then of course we've got the measurements that are taken and nobody's acting on them. A clinical decision based on these results can be detrimental and consequently lead to patients' death. Thank you for listening.